Good evening, everyone, and welcome back to the Lipid Panel. My name is Dr. Guy Mintz, and I am the co-chair of programming for the Lipid Panel, working alongside with Dr. Merle Myerson and Brittany Thompson. The Lipid Panel was conceived to be a lipid clinic conference on a national scale. For those of us lucky to work in larger institutions, we have in-house colleagues. Lipid Clinic Conference as a great way to debrief after busy clinical days and review diagnostic approaches. But for others, having the ability to reach out to someone close by may not be that easy. So this is an opportunity for us to present cases on a monthly basis, generate therapeutic strategies, clinical findings, and come together with colleagues. We're not on lipid islands. Conferences like this remind us that you're not alone. If any of you have cases or topics that you would like to present or discuss at future conferences, please email Brittany Thompson at bthompson@lipid.org with your suggestions. In this series, we review common presentations of rare diseases, atypical presentations of common condition, sometimes even common presentations of common conditions, and we will try to cover as many important topics that every lipid specialist needs to know. This series is meant to be a monthly coming together of rising stars, like the FNLA Lipid Scholars Program and early career lipid specialists with more experienced colleagues. Look for our scheduled posting for the final Tuesday of every month. And tonight's topic is going to be diabetes, the role of GLP1 agonist therapy. We are joined this evening by Dr. Merle Myerson, who is going to be our moderator and case presenter. Dr. Myerson is a board-certified cardiologist and lipidologist and an expert in the area of prevention of cardiovascular disease. She was the founder and director of the Cardiovascular Disease Prevention Program at Mount Sinai, St. Luke's Roosevelt Hospital, New York City, was at the Dartmouth Hitchcock Medical Center, where she led the lipid clinic, now working as a medical and health writer and consultant. We are also joined by Dr. Wyne, who is an adult endocrinologist specializing in the management of diabetes, lipids, and hypertension. She is the director of the Ohio State University Wexner Medical Center Type 1 Diabetes Program. She's also been on the board of directors of the American Association of Clinical Endocrinology and the National Lipid Association. We are also joined by Dr. Cindy Bredefield, who's an attending physician at NYU Langone Diabetes and Endocrinology Associates in Long Island. She's an assistant professor of clinical medicine at NYU Long Island School of Medicine. She is the director of diabetes and lipid clinical trials at NYU Langone, Long Island, and principal investigator of several randomized controlled trials, including co-investigator of the American Heart Association cholesterol lowering and residual risk in type 2 diabetes trial. So with that, I welcome you all to this evening's program, and Dr. Myerson will present the case.
Hey, thanks, Guy. So this Elena is a 48-year-old Hispanic female with type 2 diabetes for 6 years, referred to the outpatient endocrinology office for diabetes and weight management. Medical histories: the type 2 diabetes, hypertension, class 1 obesity, dyslipidemia, and GERD. Surgical history: right knee arthroscopy. Her gynecologic history is G2, P2, history of preeclampsia and gestational diabetes requiring insulin with her second pregnancy. Second newborn weighed 9 pounds, 2 ounces. At present, she's on metformin 2,000 milligrams daily, losartan 50 milligrams daily, and over-the-counter omega-3 EPA and DHA, omega-3 fatty acids, 500 milligrams daily. So just stopping here for a minute, I think we can all look at this and say, this is probably a patient who will need a lot of issues addressed. Fortunately, has been referred to an endocrinologist. So our panelists, any thoughts initially here?
I think that I would start off in just saying that this is what Guy was alluding to, is that this is a common case of a common problem. So this is something that we see every day in the outpatient setting, and really has features of, we'll get more into the physical examination, but a lot of features that we see in terms of metabolic syndrome with diabetes and obesity, a prior history of gestational diabetes, macrosomia in her infants, and even another risk-enhancing factor. Here we have a preeclampsia. So this is a very common patient that we see, typically already on metformin. One thing that I would mention right out of the gate is often we see this over-the-counter type omega-3, and we'd be interested to see her triglycerides and really to get into whether that is something that is of any utility for her. And moving forward, what medications, notably the GLP1s, how that can significantly ameliorate a lot of the metabolic derangements that are mentioned here.
Right. So before we go on to the second slide, yes, I think now this is definitely a new generation of medications that are coming out. And I think this case allows us to find out how and where we integrate them into care. Next slide, please. Family history: her mother is a 74-year-old with obesity, type 2 diabetes, dyslipidemia, and hypertension. Father, 76 years old, obesity, hypertension, non-fatal MI at age 65. Paternal grandfather, deceased with fatal MI, age 58. And brother, 45 years old, obesity and hypertension. She has a fairly sedentary lifestyle, working as a bus driver, does not smoke, and does not use alcohol. Her diet, she says she's not really doing too well with this, has a lot of snack foods, such as pretzels, potato chips while driving the bus, comes home, has large dinners that are carbohydrate heavy in the late evening. So I think here one important thing is we're going to talk about the medicines and the drugs, but this patient also, when we see the management plan, we know that there'll probably be a lot of lifestyle modifications. So to our presenters, has she had any previous intervention, nutritionist, diabetes educator?
No, she is seeking, that type of counsel. Right. For sure, one of her biggest concerns in terms of her management, particularly with, medication management, also is that she works as a bus driver, and she's concerned that she will be on any medications that would provoke hypoglycemia. So she was quite interested in lifestyle management, as well as any medications that would not be implicated in that. She does seem motivated to improve her sedentary lifestyle, and stop the snacking while she is on the bus.
So, before we jump forward, though, I think it's important to raise an issue that Cindy kind of just mentioned and alluded to, and it has changed in recent years, in the issue of being a bus driver with diabetes. And some people know the issues, some people don't know there's an issue, and other people just think, oh, you can't have insulin if you're going to have that kind of driver's license. But the important thing is if you know someone works as a driver, they need to have a DOT license, whether it's a local or an interstate one, you really want to kind of jump on their diabetes as early as possible and be as aggressive as possible to keep them safe and keep them able to be driving for as long as possible. Importantly, and one of the things that's misunderstood, it is very clear that someone can have a license, a commercial license, and be on injectable medications. There's no issues at all if they're on injectables such as GLP1s. There are situations where they can be on insulin, but it's a whole ton of paperwork that we have to do. And interestingly, for that DOT license, they've become very sophisticated. For me to sign for someone to be on insulin with one of these licenses, I actually have to verify that the person wears a continuous glucose monitor and that I have a 90-day electronic download of that data before when I sign for it. So the point being is that they do have options, even though it's paperwork for us. But importantly, you would want as early as possible, once you know they need a commercial license, to be very aggressive, going to combination therapy, not maxing out your metformin, adding a second and maybe a third agent so that the person can keep working in that job. And I know it's a little bit different than saying what medicines should she be on, but the moment we see that a person's driving, for us, that really changes the conversation. You know, what are your career goals? Where are you going to go? How long do you want to keep doing this? You know, and addressing those issues. So I think that's an important side point that does need to come up.
Yes, well, thanks. That's a very good point. This person has comes with many risk factors, and added to that, her occupational issues. So really a good case, I think, with a lot of learning points here. Next slide, please. So on physical exam, her blood pressure is 140/82, heart rate 84, body mass index 33. And her physical exam, she has central truncal distribution of obesity. The skin was remarkable for acanthosis nigricans, nape of the neck, bilateral axilla. She didn't have any other physical findings here that were remarkable. So just one question is, what has her blood pressure been? You know, it's a little high here in the office. I'm thinking that, you know, given her overall control of her risk factors, it probably has not been optimal.
Yes, and one of her motivations, you know, was her obviously very strong family history of heart disease. And she admitted that she had not been really seen by physicians or been examined for quite some time. So she's really presenting sort of anew. We don't have much historical information of her metabolic control. And here we're starting to see really one thing that I think would be helpful in the physical examination too, although it's mentioned central distribution, but a waist circumference would be really a helpful part of the physical examination. And she's starting to really meet, you know, several criteria for metabolic syndrome, including, you know, her blood pressure. I would imagine her weight or her waist circumference, and then we get into some more of the laboratory findings. I think we'll find the same to be true. Importantly here, the case is sort of pushing the doctor away from more of a Cushingoid presentation, but again, rather this is just a very common presentation of our patients with obesity and type 2 diabetes.
You know what, Cindy, what's interesting about a couple of those things, you mentioned waist circumference. So when the metabolic syndrome came out and said, you know, here's the criteria, we should be measuring waist circumference, we asked Epic, who's the medical record we were on at the institution I was on, and many institutions are on Epic. We asked them if waist circumference could be added to the vital signs. And their response was, oh, well, that would take a major upgrade to do it. And we said, well, fine, but you know, this is now part of standard of care. We really need it. And I don't know if your institutions use Epic, but as you can see, it's not there yet. So obviously not enough people are telling Epic, hey, we need waist circumference in addition to blood pressure, heart rate. You're absolutely right that we need it. But if it's in that list, as you know, we're putting patients in the room, it's more likely to get done. And that's the point I wanted to raise, is we really need it just as a standard vital sign.
Yeah.
There is one other point I wanted to raise with her vitals, and this is something that we've been talking about recently and teaching our students, is in terms of blood pressure targets with diabetes. For a long time, our target had been, you know, below 130/90, below 130/80. After the Accord trial, they took it back to 140/90. And this last year, the American Diabetes Association has brought it back down. So, we're often saying, well, it's the first visit in the clinic. The blood pressure might be a little bit high. She needs a home monitor. She needs to do some blood pressure logs. But it's really important, and this has always been a topic in hypertension, is the missed opportunity to address the blood pressure. And given that, maybe 50% of people are actually at that target of 130/80, maybe this is an opportunity to change her losartan to BID rather than saying, oh, let's work on these things. Now, you guys are probably saying, wait, but if we give her a GLP-1 and she loses 10 pounds, and I'm going to say you're absolutely right. I know I'm jumping the gun, but, with her cardiovascular history and her blood pressure, we need to think about maybe this is an excuse to raise her losartan. But you've got the flip side of if we do an intervention, even 10 pounds of weight loss may have a significant impact here. But these are the things we need to have in the back of our mind when we see this blood pressure, really.
Right. Well, I think you bring up a good point too, that we need either ambulatory 24-hour blood pressure monitoring, or some studies have shown that if you instruct a patient how proper to take their blood pressure at home, you can actually have them keep track and get some very good numbers as well. So, yeah, I don't know if an electrocardiogram was done and whether that showed LVH too. That can give you an idea of perhaps she has not been well controlled, which is what I suspect. All right, let's go on to the laboratory findings. So her A1C was 8.6, total cholesterol 200, HDL 39, triglycerides 216, LDL 118. So right there, we're seeing a metabolic syndrome type pattern, plus her LDL would be higher than a goal. The microalbumin is elevated as well, so indicating some renal issues here. AST mildly elevated, ALT also mildly elevated. Any comments on this initial blood testing here? I'm not sure if you have any past blood tests, what her A1C has been.
No, again, so she was a fairly new patient, again, seeking more help in terms of her metabolic management and diabetes, obesity care. And again, definitely seeing here a metabolic syndrome picture. And, going back to the medications, as Kitty had mentioned, with the losartan probably needing an adjustment, we also see a patient that was not on the proper lipid lowering medication either, not on a statin, nor had she ever been on a statin. And rather was taking a very low dose of over-the-counter omega-3. She had, for the first time, this finding of a microalbumin. She did not recall ever having this test previously, as well as she was never told of transaminitis, which, in this case, we were worried about hepatic steatohepatitis or steatosis. And again, jumping the gun a little bit in terms of how to go about addressing some of these metabolic derangements, what will be the role of the GLP in terms of taking care of a lot of these potential problems via weight loss, as opposed to, more selective therapy, for example, targeting her non-HDL or her triglyceride, rather, what can weight loss get us in terms of normalizing these parameters, as well as the transaminitis.
It's interesting because it's like, on the one hand, I want to jump and let's talk about what a GLP-1 could do for her. But before we get there, you guys are absolutely right that there are issues to address here. With respect to the microalbumin, 98 is high enough that I personally would say, I'm going to double up on your losartan right here. Now, we can come back later and talk about potential renal benefits from the new diabetes medicine. But still, a standard care right here would be 25 of losartan is a low dose. Blood pressure's on the high end anyway. I would immediately increase that dose right there. But the other thing I wanted to say about the AST and ALT, and obviously the concern is fatty liver disease. First of all, I don't know if you or the audience know it, but the hepatology world has changed the name.
Yes.
So it's, what is it? Metabolic dysfunction associated steatotic liver disease. So it's math,
It's
math.
NAFLD.
So it starts with an M instead of an F now. But so one thing is I just wanted to raise that because people are going to start seeing the new abbreviation. I like the new abbreviation because I understood historically where NAFLD came from, but I always felt it had an odd connotation of I'm judging you and saying you don't drink alcohol, but what does alcohol have to do with it? Anyway, what we would do with this patient here is our next step, speaking from the fatty liver side, is we would calculate what's called a FIB-4. And the FIB-4 actually in EPIC is what you call a system-wide smart phrase. EPIC has pre-programmed it. You just put .FIB-4 and it calculates it for you. And FIB-4 is a calculation that includes your transaminases, your platelet count. I forget what else is in there. And basically, if the number is above 2.67, then you need to proceed with a liver evaluation, such as a FibroScan and so on. And so I think it's important for our audience not just to know about the name change, but to know, yes, we don't even know her A1C. So probably glucose control is going to be important. But from the liver perspective, the next step would actually be to calculate this FIB-4. And you can do it by hand. I'm lazy because I just .FIB-4 and it does it for me. Or it does it and says, sorry, you don't have the parameters needed. They haven't been measured in the last year. But that's really the next step nowadays. And the reason the FIB-4 has been promoted is it's non-invasive, and it's a way to try to discriminate who needs further testing with respect to their liver.
Very good. So we are on the next slide. Can bring that up here. I think this is a very good slide showing us that, this is a complex patient and there's many things that we want to do for her and with her. So we inform Elena that we'd like to discuss lifestyle modifications, which we touched on a few slides ago, and medication management, specifically with the GLP1 to improve several aspects of her health. So looking here at the GLP1 and all the problems that she has and how it can impact on that. So I think that looking at, we want to focus on the GLP1. I think I have a few questions first as we go into that. We talked about her albuminuria, her weight, what would be our goal for A1C, and our lipid goals. So let me add that to our plan discussion. Okay, and panelists, do you want to start with some of the issues one by one? Do you want to, we can go right to the GLP1. Obviously, that's a focus of our talk tonight.
Well, I think I would just start off and say, and I would like to get, Kitty's approach on how she would manage this patient, because when I take a step back and I look at this patient, I would really jump into the GLP-1. I agree that there's proteinuria, and we have suboptimal blood pressure, and there's definitely room for improvement in her low start, and no doubt. Working with patients day in and day out, one observation I have is that, they're not fond of polypharmacy. They're not necessarily fond of, doing 2 and 3 different medications at one time. They do like a more of a sequential approach, even if, I have thoughts of, going up on low start and maybe an SGLT2 is hitting my mind. What can we do with the GLP? She's not on a statin. So I think that I would really organize this into 2 buckets. And the first thing I would do for this patient would be to introduce, the importance of a statin. I would work to get her on at least moderate, and based off of her family history and her other enhancing risk factors, other comorbidities, I would work to get her onto a high intensity statin as well, and off the over-the-counter omega. So that would be sort of my lipid medication management, and we can sort of, move into targets. And then my next sort of bucket of how I would manage would be a GLP. And in effort to hit all 5 of those, issues that are brought up, that with weight management, that would translate to improvement in all of these metabolic derangements, seeing the efficacy of this, seeing what with weight loss, what is the next lab set with the results, and what is the A1C, what is her protein in the urine, what are her liver enzymes, and then take it from there in terms of either adding additional therapy or further titrating her medication.
Right. Just before we forget, I probably would add on an low-dose aspirin as well, which she hasn't been on.
Exactly.
Yeah, but okay. And Dr. Wyne, any comments?
I think one thing, you're absolutely right that all these things need to be addressed, and we have a certain perspective on what we think is important. I would be concerned about her cardiovascular risk. She's only got 6 years of diabetes. Once she's up at 10, I'm more dramatically concerned, but I'm still concerned because she has risk. And even more importantly, because she has the albuminuria, we know that's associated with CV risk, more so once the creatinine starts to rise. But the hepatic steatosis is also associated with an increase in CV risk. So the question to me is, if you had to do something next, is it more important to lower blood pressure or get her onto a statin? And in that respect, I would say blood pressure is not so bad, and there's zero statin here. Statin's going to take time to work, so that's probably a high priority. Again, remembering we don't know her A1C, but I would take it back to, as Cindy mentioned, the pragmatic reality of a patient. And my question to the patient would be, I would say, look, I'm concerned about these issues, but what is the most important thing to you? If I want us to work on this, what do you want to work on? And how do we figure out a way to mesh these two together? And if the person tells me weight is their overriding concern, then I'm going to open up a negotiation of, okay, if we can get a certain amount of weight loss, that'll lower your blood pressure. You're probably going to still need more medicine for the proteinuria, but I'm willing to work with you on that one. I'm still going to be worried about the lipids, so I'm going to try to negotiate some dose. But again, I need to know what's motivating her and what she wants to focus on, because that may change the order and how I address things. But in my mind, I'm not just looking at what are we doing today. I'm looking at all of these 5 elements in terms of where do I want this patient to be in 6 months, 1 year, 2 years, and 5 years. Now, where she is in 6 months may not be exactly where I wanted, but we're both going to be where we want to be in 1 year and 2 years. Does that make sense? The sequencing may not be the one I prefer, but it's a give and take as long as we get to where she truly needs to be in the end. I look at the long-term plan, not the short-term win. So
I completely agree with what you said regarding the pragmatic reality of managing these patients. And they've been on, the GLP1s have been on the market for some time now, so it's not really a big secret that they're weekly injectables, but at least in the beginning, there was a little bit of pushback with the fact that it was an injectable medicine. But my observation is that by and large, patients want to be healthy, of course, but once they're so frustrated with the weight management from such a long period of their life, that once they really see that there is a practical solution to that, it is an extremely motivating choice. Mm-hmm. And what I have found is that, and we'll review some of the weight loss that's associated with the GLPs, and of course, apart from insulin, they're really the most potent glucose lowering medication on the market. So her A1C was 8.6, right? So if we need to get her down to at least a 7%, we can talk, even lower. Really, there's nothing on the market besides insulin that's going to take you down that far besides a GLP-1. And then what I have found is that, once we do have patients on these medications, they do finally see some results in their numbers, in their weight. It is an extremely motivating situation. And then they start to improve their diet even more so. They're more inclined to be consistent with their physical activity. And the entire thing just dominoes into a successful, situation. So that is why, by and large, I would prioritize GLP-1 in her management.
And Cindy, in doing that, you're actually following the American Diabetes Association guidelines. And this is something we've gone through recently with our house staff. Is in 2021, the top of their algorithm still said, start with metformin. They downplayed it in 2022, and in 2023, metformin is just add whenever. And really what American Diabetes Association now says is, what are your compelling indication for medication? And so nowadays, someone like her would not have started on metformin to begin with as her first line therapy, would never have been maxed out. And so really, now that we've kind of danced around the GLP-1, how about if we jump in and talk about them?
Right. Well, I think that would be good. We also have two very recent information. The New England Journal studied the semaglutide and the cardiovascular outcomes. So, in thinking what we're going to reach for, also the newly approved Zepbound, which is tirzepatide, which is not only a GLP-1, but a GIP, and seems to have a greater potency in terms of weight loss. So, right, I think we should delve into that. And now, we have choices. So let's hear what you would choose.
That's a great question. That's where I was going to lead off to. I think, we can talk about really the different, under over on the efficacy of the medication. My preference today is more tirzepatide, and mostly because of its not only its glucose lowering power and its weight loss efficacy, but overall side effect profile of the medications are mostly GI related. Most of these medications do induce at least a mild nausea, some degree of either constipation or diarrhea. And what I would say is that I find the side effect profile, number one, to be extremely varied. There seems to be an extreme individual difference between the dosing of the medication and the medication itself. Some patients I've even had gain weight on the medication. So, it seems to be a very spectrum of adverse side effect profile. But with that said, there seems to be an improvement with the dual incretin, the GLP-1 and the GIP, that of tirzepatide. And that in terms of, diabetes management is not the Zepbound. That one is specifically indicated for weight loss. Rather, this is about the brand name of Mounjaro.
Right. Right. So for those of you, it had been already marketed as Mounjaro, and it's not only a GLP-1, but it's also a GIP, which is a glucose-dependent insulinotropic polypeptide. So it's a multi-agonist pill.
So how about if we kind of jump back and look at this a little bit and say, okay, so the history of this class, these GLP-1s, they were recognized as they're actually receptor agonists, but what we've got is an analog of a hormone that's naturally made by the gut, right? And then that hormone, actually, its primary action is as a secretagogue. I think we have a slide that kind of shows some of this stuff, but its primary action is that it acts on the pancreas to facilitate insulin secretion in a glucose-stimulated fashion. And then when we started seeing some of these other benefits, for example, the weight loss, the original thought that was that's related to the nausea, right? So then people eat less. But now we're seeing much greater weight loss than we saw with the initial ones. And so what we're starting to really realize is these GLP-1s, first of all, do a lot more than just facilitate insulin production by the liver. We're starting to see that they're really having beneficial effects on all the organs that are involved in glucose homeostasis. And if you're improving glucose homeostasis, you're also going to improve cardiovascular parameters and inflammation and risk. Would that be fair to say?
That would be fair to say. And I mean, along those lines too, not to lead with the audience thinking that the weight loss, is multifaceted. It is not necessarily just a function of nausea.
Exactly.
There's definitely a reduction in gastric emptying and in peristalsis, and I can touch on, some of the practical issues of that around surgery and colonoscopies that have sort of come up. But what's interesting is that these medications really touch on the appetite center of the brain, like the hedonic desire for food intake, and it really just sort of zaps the appetite, really not in a nausea-provoking way. And interestingly enough, there have been reports, of people that struggle with drug and alcohol use, that being on a GLP-1 has actually been, useful in that regard too. And also, like Dr. Wyne had mentioned, is that the way these GLP and the GIP medications work are in a glucose-mediated fashion. So they're secreted after a meal, and they work in concert to promote postprandial insulin secretion. So what's beneficial about these medications and to our patient is that they do not provoke hypoglycemia, because they don't have really that effect on the insulin, if the blood sugar is not above normal range. So in our patient that was a bus driver, a lot of misconceptions about injectable medications. Sometimes people think that they are an insulin-based therapy. And even the DOT, I had to sort of talk to people over there that it's not an insulin, but she would be safe on this medication in terms of her occupation.
And what's also interesting is, like, you've hit bringing it back to the patient. If you look like in the top left corner where it has the liver, we definitely do see a decrease in the hepatic steatosis when people are taking these GLP-1 medications. And exactly opposite down in the bottom right corner, it points out that we do see an increase in lipolysis, decrease in lipogenesis, leading to a decrease in fat mass. So these are things that are going to help to improve insulin resistance, decrease circulating free fatty acids, but also you're going to see decreased weight in response to these changes. And as we've gotten what we kind of say the newer GLP-1s, but the longer acting, and then finally this dual agonist, the amount of weight loss has actually increased with the longer acting agents. And then something we can also get to is the differentiation of which agents and what doses are approved for weight loss as opposed to diabetes management. And that weight loss approval is for people with or without diabetes. So that's an important distinction to have with this class of agents.
Yeah, and not to, and we can get back to some of that data too, not to get too far ahead of ourselves, but in the pipeline, of course, are additional medications, and they're working on another molecule called retatrutide that actually has 3 different targets. And in that particular study, there's evidence to show that up to 95% of people had complete resolution of their hepatic steatosis. So really the pipeline of these medications and the generation upcoming are really encouraging in terms of tackling many problems at once in terms of the weight loss.
But that pipeline is a ways away. And if we come back to, like she mentioned about the version of tirzepatide that's now FDA approved for weight loss, we talk about tirzepatide for diabetes that will see a decrease in A1C of up to 2.4, 2.6. We'll see, for example, 26 pounds weight loss. But when you go to the higher dose of tirzepatide and you're doing it for a weight loss study, they're seeing on the order of 35, 45 pound weight loss, really in a short period of time in people both with diabetes and without diabetes. So that's an agent that's essentially available. It's just a matter of them finishing packaging it and putting it into pharmacies. It's FDA approved. We have the data. So we have the ability for our patient to lose the amount of weight she wants to lose just with the drugs currently available to us now.
So I should mention that the drugs marketed for diabetes and the ones for obesity or weight loss, those ones are generally at higher doses of the GLP-1s, which actually is important because, you know, we really don't know the long-term side effects of it. We assume because they've been out there for a long time as diabetes drugs that we won't see anything new. By the way, the tatrutide is now in phase 2 trials, and one of the studies was published in New England Journal of Medicine in August of 2023. So certainly looks promising. It also looks very potent in terms of the weight loss and other advantages. So there's also some oral drugs being developed as well. Currently, the ones we use are injectables. But back to which ones? So any thoughts on what you're going to reach for?
Whichever
Honestly,
one the formulary lets us.
whichever the one.
Right.
So you know what's interesting, as we got tirzepatide on the market, as expected, the insurance formularies wouldn't just give it to us. And what sometimes they say they have to have failed one GLP-1. Sometimes they say they have to have failed 2, which is really just a stalling tactic. Very frustrating. But there are some commercial insurance carve-outs. For example, there's a town in Ohio where most people are on the insurance for the local factory, and tirzepatide is first line preferred. Everybody in that town is on tirzepatide. They don't have to go by way of here and there to get there. But we're starting to see it a little bit easier to get. But quite honestly, unfortunately, even though we would like to go to tirzepatide as our first line therapy, the insurance companies dictate the practice of medicine. And so we generally go through either semaglutide or dulaglutide first before we get to go to tirzepatide.
Right. So yeah, and just as a reminder, Medicare does not pay for these drugs unless you have diabetes. They will not pay for any obesity drugs. But now with the new study just released in New England Journal about the cardiovascular benefits of semaglutide, hopefully that will start encouraging more insurance reimbursement. I believe that the pharma is now submitting to FDA to add that as to their label. So, but I think, it's a very good point. What is going to be reimbursed for our patients, what will still cost them a lot of money as well.
It's interesting. We tend to forget that there's an oral version of one of these. There's an oral version of semaglutide, so you don't have to do the injection. And it came up recently where a patient was like, can't I just take a pill? And I was like, oh yeah, you can. We forget about the pill. So we went ahead and ordered it. And we've been fighting with the insurance, trying every which way. And it's like, so you'll let her have the once a week injection, but you won't let her have the pill. It's the same molecule. Yeah. So, but it would make sense to go straight to the oral before the injection, really.
Right. And many would prefer that as well.
So I actually don't find that in my practice. I actually don't find that the patient wants, because I don't know, this patient, it wasn't on that much, but of course our patients are, on so many medications, that the way that medication needs to be taken is so specific, or else it's a tic-tac, right? Like it really needs to be on an empty stomach for a very long period of time, for at least 4 hours, and to really get a real effect. So I don't know. I actually find in my practice that they're not too, once I tell a patient that there's going to be robust weight loss, I can pretty much get most people on a once weekly injection. And I actually find that they prefer that over a pill. It's just my observation. The only other thing I would say, that just a point to bring up, is that these medications that we're talking about are really starting to rival the weight loss that we see in bariatric surgery.
Yes.
And I think, correct me if I'm wrong, I'm not sure if I'm not stating this correctly, but I believe the BMI baseline in the GLP trials, which actually lower than, the trials with bariatric surgery. So we're actually dealing with a patient at a lower BMI who's having like a, substantial weight loss. We can show some of those slides, of 22% weight loss, which we would say, is clinically relevant around 5 to 7%, so it's triple that. And, so it's really becoming, quite a game changer for patients.
Right. Yeah, the trials were a BMI of 30, I believe 30% or 27, but with a major obesity-related disorder as well, where generally bariatric surgery has been higher. But yes, they are showing a similar percent weight loss. I believe we have a slide with some data here too. So if one of you would walk us through this.
Sorry, I have to move this presenter. So what we have here is a study familiar probably to many people in the audience. Over to our left is the SUSTAIN trial with Ozempic, or semaglutide in that cardiovascular outcome trial. And what we're trying to show here was a very robust reduction in mean glycated hemoglobin. Baseline here was just above 8.5%, and the majority of patients got to target down to 7% with some increase over time. Similarly, there was a significant weight reduction in this particular trial. It was about 10 pounds. So if they're starting at about 92 kilograms, it was about a little over about 5% weight loss, which again is clinically relevant. However, when we come over to the right side of the screen, what I'm showing here is the SURPASS-2 trial. Now, this is the tirzepatide. This is the dual incretin GLP-1 compared to semaglutide once weekly in patients with type 2 diabetes. And really fascinating A1C reduction, baseline around 8.5 down to about 5.8%, which is really just remarkable. And again, what I really think just, as an aside, what comes into this is the motivation of the patient. Once they see these results, they become highly invested in their care like they've never been before. Along the same line, you see over on the right on the top is a change in baseline weight, and there is a 12.5 kilogram weight loss, which is really remarkable. Really no other weight loss medications have given us that degree of weight loss. And similarly, I just show down at the bottom, again, the dual incretin with tirzepatide. This is in patients just with obesity. The majority of these patients actually were pre-diabetic in this trial. This is the SURMOUNT trial, but they weren't technically with type 2 diabetes. And similarly, as in patients with type 2 diabetes, there's about a 22% change in body weight. So this is really encouraging. And like I said, typically what I would do is go for a medication like tirzepatide in the patient that was presented, and then upon follow-up, reassess her metabolic parameters, and then decide if additional therapy is needed. But this is why before adding additional medications in terms of triglyceride lowering medication or maybe even blood pressure medication, you can go both ways with that. Certainly, an SGLT2 inhibitor, I would go for this first.
Okay, well, I think we're getting to the end of our talk here. Thank you very much. I think that we have a new era here in treatment of diabetes. It's very exciting because the medicines that are coming out not only help the diabetes, but all of the associated cardiometabolic abnormalities as well. So for this patient, certainly it was a very typical of a patient who would benefit greatly from the GLP-1. We also talked about the importance of getting her LDL down, treating with the statin, blood pressure, diet. The GLP-1 will help with the weight loss, but certainly exercise and nutrition counseling. So any final comments from our panelists? Okay, I think we did have a question come up about nausea on the GLP-1. Anyone, I know that GI side effects are often listed with these studies as well.
Yeah, I mean, extremely common. I certainly counsel patients on this. One of the biggest talking points I offer patients is that when they're initiating the medication, my observation is that the biggest side effect of nausea is within about 48, maybe even 72 hours. It's not immediately. And it is very important when they initiate the medication to watch portion size because of the delay in gastric emptying. So you don't want them, that's not the best time to go out for a buffet when they're starting the medication.
Right.
And certainly upon titration. And that, I've had people, get a little frustrated with how slow the titration is because it's starting with a low dose once a week for 4 weeks, so an entire month before typically we're moving to the next dose. So sometimes patients like to push it a little bit faster, and I don't recommend that in terms of side effect profile management.
And also, if you look at the incidence of nausea, it is highest for the first couple doses, but generally it takes about 3 months to really kind of settle itself out. And, we're being told, push the dose every 4 weeks, every 4 weeks. And we have to kind of balance that with getting the patient to be honest about their side effects. Sure, they want to get to the high dose and get, as much benefit as quickly as possible, but we sometimes have to go a bit slower, even slower than people want, just to minimize those side effects. And unfortunately, some people do stop. Sometimes they can kind of stretch out the dosing interval, like doing it every 10 days instead of every 7 days. Sometimes that helps a little bit also in terms of tolerating it. And, the other thing is just going slower on their titration.
Yeah, that's a point, I think, Kitty, that gets missed in my practice. I think a lot of times patients assume that they have to go to the next dose. And that, I think that gets missed in conversation a little bit, and that really leads to a more successful initiation of the medication if you really take your time to counsel them in terms of how to mitigate these side effects, including that there's no pressure to go to the next dose.
Yeah.
All right, well, very good points, and I think some very practical points too from those who are, we can all read the studies, but when it's the providers in the trenches and know the realities, which, we've discussed here, some of the side effects, paying for the medication, reimbursement. But overall, I'm glad that we have brought this out. Any questions, certainly send them into NLA. I know this was not a live session. This was recorded. So we'd be glad to address any questions that any viewers have when they watch this. Thank you very much for everyone, and very much appreciated your time in presenting the case and discussing it. Thank you and good night.